other classmates. I think we are complete now. We have a total of 97. Mm. So good morning. Can you hear me?
Yes, good. Can hear you.
So I'm Dr. Nico Olivar, and I will be your preceptor for this. I think we will have a 3-day schedule tackling tumors, disorders of the epidermal nevi, or wait, paano ba mag-auto? Sorry, wait, I'm just so your disorders of your skin appendages, your pigmentation disorders, etc. So I just share my screen. Can you see my slides?
Yes, good.
Okay, so again, good morning. I'm Dr. Olivar, and I'll be your lecturer for 3 meetings. So these are our objectives for today. Ideally, we should be finishing 3 chapters today. However, because there are many subtopics, I decided to just discuss the third chapter next meeting. So basically, we will be tackling about tumors. One of the most boring topics in dermatology. I don't know if that's just me, but I won't actually take it against you if you fall asleep while I lecture. Kidding aside, this topic is really challenging since it also incorporates more of dermatopathology. So you don't need to take pictures. I will just send you a PDF file of my lecture. So anyway, let's start with your vascular anomalies. So your vascular anomalies are overgrowths of your various types of your blood lymphatic vessels. They can either occur in isolation or as part of a syndrome caused by localized or generalized genetic mutation. So the International Society for the Study of your Vascular Anomalies is created. So they created a classification system that becomes the standard way of categorizing vascular lesions. So your vascular malformations, these are more static but can still grow. In contrast with your vascular tumors, these are your dynamic tumors and they exhibit rapid growth. So under your vascular tumors, you have your benign, your locally aggressive or borderline, and your malignant classification. So this is just a list of your vascular tumors and their classifications. Although I just chose some topics that are common or something that you should learn at your level. Unless you want to join us at dermatology, you can do advanced reading. Anyway, Let's start with the most common benign tumor of childhood, which occurs in approximately 4 to 5% of children. So importantly, your infantile hemangioma are either not detectable at birth or present with a patch of vasoconstriction called your premonitory sign. So your risk factors include your low birth weight, female, multiplex, prematurity, maternal age more than 30, and the strongest predictor is your low birth weight. On histology, there is noted benign proliferation of tightly packed endothelial cells, and it is important to note that it stains with your CD133 and CD34. Treatment includes your beta blockers, propanolol, atenolol, and your topical timolol. Also give your systemic steroids, and you can also do your NDAG and KPP lasers. So your infantile hemangioma grow through a characteristic growth pattern with rapid growth occurring most commonly in the first 6 months. Although they can grow up to 12 months, most rapid growth is between 5.5 and 7.5 weeks of life, and 90% are finished significantly growing by 4 months. Next is your congenital hemangioma. So we have three major subtypes for your congenital hemangioma. We have the rich or your rapidly involuting congenital hemangioma. We have your non-involuting and your partially involuting congenital hemangioma. So these are fully formed tumors at the time of birth and do not proliferate in postnatal life. So on histology, your rich and your niche are rare GLUT1 negative vascular tumors and can actually note mutations in your GNA11 and GNAQ. And treatment includes your surgery or embolization for ulcerated or bleeding lesion. So again, these are the three major subtypes of your congenital hemangioma. So they differ morphologically. So for your rich or rapidly involuting congenital hemangioma, usually, as you can note, there is a raised biolaceous tumor with large radiating veins or with overlying telangiectasia and halo of pallor. So your central ulceration may be present and it actually evolutes spontaneously by or before 14 months and leave residual atrophic anatodermic scar tissue. So this can also be associated with your mild to moderate thrombocytopenia and coagulopathies as characterized by elevated fibrin degradation products and low fibrinogen in the neonatal period. So for your non-involuting congenital hemangioma, these are actually less common. They present at birth and in comparison with their pitch, they usually are flatter and they present as a well circumscribed, round to oval, indurated, or raised soft tissue mass, also with overlying telangiectasia and the rim of pallor. For your partially involuting congenital hemangioma, they occur over the first 12 to 13 months of life before your stabilization occurs. And these are associated with your GINA Q and GINA 11 as mentioned a while ago. Next is your pyogenic uh, granuloma. So your pyogenic granuloma are actually your small eruptive, usually solitary sessile or pedunculated friable papules. So this lesion is common in children but may occur at any age, especially during pregnancy or with medication use such as your isotretinoin, etc. So your pyogenic granuloma occurs most often in your exposed areas, so on the hands, on the forearms or face, or at sites of trauma. So in pregnant patients, we can actually note your granuloma gravidanum, which are lesions occurring on the mouth, especially on the gingiva in pregnant women. So your pyogenic granuloma actually bleed easily on the slightest trauma, and if cut off superficially, they promptly recur. On histology, they are noted to have your globular capillary hemangioma with lobules separated by a connective tissue septum, and treatment is by curettage or shave excision followed by destruction of the base by fulguration or aluminum chloride. Silver nitrate alone may be sufficient to treat your smaller lesions but may leave a silver tattoo. And can also give your topical timolol, your imiquimod, your imiquimod under occlusion, and your sclerotherapy with your monoethanolamine albate or sodium tetrahedrosyl sulfate, which are noted to be successful in the treatment of your pyogenic granuloma. So if there is a recalcitrant pyogenic granuloma, we usually do your excision or your laser ablation, and those with giant pyogenic granulomas are given systemic corticosteroids. So we move on with your vascular anomalies. We have your hemangio endothelioma, which are a group of tumors that span the spectrum from benign to low-grade malignancy. So there are different types. You have your capuciform, your spindle cell, your epithelioid, your retiform, and your epithelioid sarcoma-like hemangioendothelioma. So your capuciform HE usually is uh, complicated. There is actually a complication, which is your Casaback-Merritt syndrome. Sorry. Nakapasok na ba yung mga nasa waiting room? I just read your message.
Yes po, Doktora. Nakapasok na po siya. Thank you po.
So as mentioned, your Casaback-Merritt syndrome is a painful violaceous mass in association with your purpura and your thrombocytopenia, and the most striking sign is its bleeding tendency. So what happens is there is platelet trapping within your vascular tumor that results to the activation of your clotting cascade and the IC. Hence, your blood picture would show your low hemoglobin, your fibrinogen, your platelets, low factor 2, 5, and 8, and there is prolonged PT, and elevated D-dimer. So, treatment includes your systemic corticosteroids, your sirolimus, and your low-dose aspirin. You can also give your interferon alpha 2A, vincristine, vinblastine, etc. So another type of your locally aggressive vascular tumor is your Dobska tumor, also known as your endovascular papillary angioendothelioma, which is a rare low-grade angiosarcoma presenting as a slow-growing uh, tumor on the head, neck, or extremity of infants or young children. So it shows your multiple vascular channels with papillary plugs of endothelial cells surrounding your central hyalinized cores that project into the lumina, sometimes forming a glomeruloid pattern. So wide excision Excision of your regional lymph nodes when involved are usually curative for your Dabska tumor. Next is your tufted angioblastoma. So this usually develops in infancy or early childhood on the neck and upper trunk, and adult onset has also been described. The lesions present as poorly defined dull red flags with a mottled appearance varying from 2 to 5 centimeters in diameter, and some shows cluster of smaller angiomatous papules superimposed on the main macular area associated with uh, hypertrichosis. So these are characterized by the proliferation of your CD34 endothelial cells with few actin positive cells. And treatment includes your aspirin, your systemic steroids, your vincristine, sirolimus, pulse dye laser, IPL, excision and radiation, embolization, and your interferon alpha 2. So for your hemangiopericytoma, clinically, hemangiopericytomas are non-tender bluish red tumors occurring on the skin or in the subcutaneous tissues on any part of the body. So the firm, usually solitary nodules may be up to 10 centimeters in diameter, and histologically, the tumor is composed of endothelium-lined vessels that are filled with blood and surrounded by cells with oval or spindle-shaped nuclei or pericytes. So uh, there is also your staghorn-like ectatic spaces. So treatment is through wide local excision, which is the treatment of choice for your hemangiopericytoma, but radiation therapy may produce excellent combination. Other vascular tumors include tertiary angioma. So these are also called your senile angioma or your De Morgan spots. These are the most common vascular anomalies, presenting as round, slightly elevated ruby red papules, zero point 0.5 to 6 millimeters in diameter. It is actually rare to see in a 30-year-old person, and the number increases with age. So most are seen on the trunk, and they are rarely seen on the hands, on the feet, and on the face. Your early lesion may mimic your petechiae, and when lesions are surrounded by your purpuric halo, it is important that you rule out your amyloidosis, or you can suspect your amyloidosis in these cases. So these are actually also noted after your nitrogen mustard therapies. So on histology, you would note your dilated thin blood vessels and light electrodesiccation or laser ablation with IPL and long pulse NEAD can be effective. So we can also perform your shave excision, but most patients accept reassurance and do not request removal of your cherry angioma. So we also have your targeted hemosiderotic hemangioma, your glomerular hemangioma, and your eccrine angiomatous hamartoma. So receiving your vascular malformations are abnormal structures that result from an aberration in your embryonic development or trauma. So this abnormality may be caused by an anatomic malformation or a functional alteration, and this are subdivided according to the type of your vessel involved. So they may be capillary, venous, arterial, lymphatic, or combined. And actually, the term capillary malformation is best used as a term encompassing a variety of entities, including your salmon patch, your certain telangiectasias, your port wine stains, your cutis marmorata, telangiectasia congenita. So another example of or a type of your capillary malformation is your Amino Simplex. So this is a type of your CM that is light pink, easily blanchable, often has a splattered appearance and located in characteristic locations along the neural axis, which tends to fade over time. So these are common birthmarks in children, approximately 80% of children. So colloquial terms are used for certain types. For example, your stork bite is a pink red macule on the posterior midline between the occipital protuberance and the tip of the spine of the fifth cervical vertebra. Angel's kiss is located on the globula. So rare associated syndromes include your Beckwith, Friedman, your Roberts Nova, your megalencephaly capillary malformation syndrome. So it's also important that you know how to differentiate it with your port wine stain. As for your port wine stain, it occurs in an estimated 3 per 1,000 children, and the stains are present at birth and vary in color from pink to dark or bluish red. These lesions are usually unilateral, and the face and neck are your common locations. So other types of your part 1 wine stain include your reticulated and your geometric part 1 stains. So in general, these lesions become more bluish or purple with age. On histology, you would note the dilated capillaries in the subcapillary network, and uh, your port wine stain may appear as an acquired condition, usually with onset after trauma. So treatment include your laser therapy, your flush lamp pulse dye 585 or 595 not laser, and your long pulse alexandrite into NDL. So note that your porcine stain is unilateral, while the Nido simplex is usually seen at the center. Next is your cutis marmorata telangiectatica congenita, which has been recategorized as a type of your capillary malformation. So this is characterized by the presence of your red, purple, livido appearing reticulated vascular network with a segmental distribution, usually involving the extremities. So your mottling is pronounced and is made more distinct by crying, virus activity, and cold. And there is often associated atrophy giving a pseudo-athletic look that outlines the muscle. So this can be difficult to differentiate from your reticulated portal skin, but typically your cutis marmorata PC has more uniformity and is more net-like. So disease associations include your phacomatosis, pigmentovascularis, and Adams-Oliver syndrome. These lesions tend toward improvement with time, but may not fully resolve. Another type of your so these are just a list of uh, your syndromes associated with capillary malformations. So on the picture, you would note Serge Weber syndrome and your Klippel-Trenaunay syndrome, which is characterized as a triad of nevus flammeus, venous, and lymphatic malformations, and soft tissue hypertrophy of the affected extremity. So these are also list of your syndromes associated with your venous malformation. So on the picture is your Mapuche syndrome, which is an aberration, the mutation of your IDH1 and IDH2 gene. You also have your Glomus tumor, which is a subungual tumor showing a bluish tinge through the translucent nail plate, which is extremely tender and with paroxysmal pain occurring frequently. Another type is your arteriovenous fistulary AV fistula, which is a route from your artery to vein bypassing the capillary bed. So your AV fistulas may be congenital or acquired. Your congenital AV fistulas occur mostly on the extremities and may be recognized or at least suspected in the presence of your varicose veins, ulcerations, and capillary malformations, while your acquired AV fistula are usually the result of trauma but may be created intentionally for your hemodialysis access. So, your so at times your reddish purple nodules or plaque may be present with a clinical resemblance to your Kaposi sarcoma, hence it's called your pseudokaposi sarcoma or your Stewart blue farb syndrome. So in histology would note increase in thick walled vessels lined by plump endothelial cells, extravascular erythrocytes, and deposits of your hemosiderin, and treatment of your traumatically induced AV fistulas by excision is curative. So because the congenital malformation variety consists of multiple small distal lesions, surgical intervention is not feasible in many patients. Hence, your color echo Doppler ultrasonography guided sclerotherapy with polydocanol microphone has been used successfully in this setting. So your sodium tetradecyl sulfate and ethanolamine oleate have been used as sclerosants in various forms of your TB malformation, and your pressure and elevation as supportive measures may limit ulceration, infection, and other secondary complications. So another type is your nevus anemicus, which is a congenital disorder characterized by your macules of varying size and shape that are paler than the surrounding skin and cannot be made red by trauma. So on it actually resembles your vitiligo, but there is a normal amount of melanin and on wood lamp, so it does not accentuate. So your wood lamp does not accentuate the lesion, and on diastrophy, it causes uh, blanching of the skin, of the surrounding skin. So on histology, lesional skin resembles normal skin, and underlying defect associated with your nevus anemicus is increased sensitivity of your blood vessels to your catecholamines. Another type is your nevus oligomecus, presenting as a patch of vivid skin that is cooler than the normal skin as a result of decreased blood flow. So vasoconstriction of your deep vessels is thought to be the underlying defect for your nevus. Another type is your sinusoidal hemangioma, which is a vascular malformation usually presenting in adults as a bluish purple nodule less than 4 centimeters in diameter on the trunk or breast However, multiple lesions may also occur, and facial mutation has also been reported in histology. It appears as a lobular circumscribed mass with dilated interconnected vascular channels filled with blood. So we proceed to your lymphatic malformations. First one is your lymphangioma circumscriptum, which is also called your microcystic lymphangioma circumscriptum. So the old term for your microcystic lymphatic malformation is your lymphangioma circumscriptum. So it presents as a group of deep-seated vesicle-like papules resembling frog spawn at birth or shortly thereafter. The lesions are usually yellowish but may be pink, red, or dark and bled into. And this creates the illusion that they are rapidly changing. So when you puncture these papules, you would note uh, clear exudations and color lessening. And the papules are noted to be arranged irregularly in groups that may be interconnected by sparsely scattered lymph cysts. So sites of predilection include your abdomen, your axilla, your genitalia, and mouth. And treatment includes your excision and grafting, fulguration, or coagulation. However, this mode of treatment are usually unsatisfactory. So you can perform your CO2 laser, PBL, your IPL, your sclerosant, and electrosurgical techniques. So another type of your lymphatic malformation is your macrocystic lymphatic malformation. So these are also deep-seated, multilocular, poorly defined soft tissue masses that are painless and covered by normal skin. So they are most common in the oral cavity and on the extremities and have been described in Masucci syndrome, which was presented a while ago. So treatment includes your on and your are used are and organs. Hi, sorry, it got disconnected. So yeah, just continue with my lecture. Mm. So can you see my slides? Sorry.
Yes po, Doc.
Okay, so these are the types of your lymphangiomatosis. However, I will just be focusing on those with the relation of your pre-existing vessels, such as first is your spider angioma, this one. So the lesion of your spider angioma is suggestive of a red spider and the ascending central arteriole representing the body of the spider and the radiating fine vessels suggest the multiple legs here. So these small telangiectasias occur singly or severally, most frequently on the face, the neck, and the dorsal hands, indicating they may be induced by sun exposure. So it's important that you ask for the history of these patients, especially history of cirrhosis or inactive cirrhosis, liver problems, hepatitis C, malignant disease of the liver, and other hepatic dysfunction. Next is your venous lakes, which are small, dark blue, slightly elevated webs, easily compressed, located on the face, the ears, the lips, the neck, forearms, and back of the hand. So these manifestations of chronic sun damage are extremely dilated, blood-filled spaces lined with thin, elongated endothelial cells and usually surrounded by prominent solar epistases. So we also have your capillary aneurysms and your telangiectasia with the following types. So we have your hereditary hemorrhagic telangiectasia, your generalized essential telangiectasia, and your unilateral nevoid. General, these are fine linear vessels coursing on the surface of the skin. So collectively, they are called your telangiectasia. So they are also prominent in areas of chronic actinic damage seen in fair skin individuals and those with long exposure to wind, cold, or heat. So another is your angiokeratoma. So in general, your angiokeratoma are collections of your blood vessels with an overlying hyperkeratotic surface. So there are different types of your angiokeratoma. You have your circumscriptum, which are noted as purple or red, well-defined lesions occurring on the lower extremities, but this can also be present on your chest or on your forearm. We also have your angiokeratoma of the belly, which are seen uh, on the dorsum of your fingers, toes, elbows, and knees, characterized as 1 to 5 millimeter red vascular papules, which becomes hyperkeratotic over time. And angiokeratoma seen in the scrotum is termed angiokeratoma of Forbes. So they have a predilection for the scrotum involving middle-aged and elderly individuals. And there is often a diffuse redness on the involved area. So uh, as for your as for the treatment, you can actually do your superficial ablative therapy or your full thickness excision. And sometimes in patients with angiokeratoma of the scrotum, reassurance. Next is we proceed to your hyperplasia. So first one is your angiolymphoid hyperplasia with eosinophilias. These are actually benign vascular growth that usually presents with pink to red brown, dome-shaped dermal papules or nodules of the head or neck. So these lesions actually present Histologically, as central thick-walled vessels with hot-milled endothelium surrounding hyperplasia of smaller vessels and nodular lymphoid aggregates with your eosinophils. Your lesions do not spontaneously regress, and treatment with surgical excision is successful in 65% of your cases. So the lesion may recur if the underlying inhibition is not excised and your intralesional corticosteroids, pulse dye laser therapy, and ultra-long pulse system together with your NDAG, cryotherapy, pentoxifenine, endomethacin, imiquimod, and electric desiccation have been successful in some patients. So in cases with in difficult cases, these are actually controlled with your interferon alpha 2. Sorry, maingay, wait lang. Sorry, maingay ba? Naririnig niyo ba yung background?
Naririnig ko ba?
Sorry, wait lang. Nasa clinic kasi. Anyway, for your Kimura disease, so you can actually differentiate it from your angiolymphoid hyperplasia with eosinophilia. It's important that you actually distinguish it from your Kimura disease. So your Kimura disease is actually an inflammatory disorder presenting as a massive subcutaneous swelling in the periauricular submandibular region in young Asian men. Histologically, they present as a prominent germinal center with eosinophils in the subcutaneous tissue, and um, important to also note that your Kimura disease is associated with your allergic conditions such as your asthma, your rhinitis, and your eczema. And it is also frequently accompanied by your lymphadenopathy, your peripheral blood eosinophilia, and your elevated IgE level. Treatment includes watchful waiting, your surgery, radiation, and your systemic steroids. So, other hyperplasia, which I won't be going into detail anymore, are the following. We have your intravascular papillary endothelial hyperplasia, your angioma, serpiginous foam, your microgranular hemangioma, and your proliferating angioendothelial cases. So we proceed to your malignant cases. So for your Capillary sarcoma, I guess you all know this one. This is formed by the proliferation of your abnormal vascular endothelial cells, and the HHV8 is found in Kaposi sarcoma lesional tissue, irrespective of their clinical type. So we have different clinical types that I will be going to discuss later on. You have your classic, your African cutaneous, your African lymphadenopathic Kaposi sarcoma, your Kaposi sarcoma in immunosuppressed by AIDS, and your sarcoma in patients with lymphoma are on immunosuppressive therapy. So, histologically, early lesions include regularly shaped ectatic vessels with scattered lymphocytes and plasma cells, and late lesions are characterized by the proliferation of vessels around your pre-existing vessels and adnexal structures. Treatment includes your radiation therapy, your local excision, your cryotherapy, your alitretinoin gel, so your locally injected chemotherapy, your laser ablation, also your vincristine, 0.1 milligram per ml of intralesional, not more than 3 ml interval of 2 weeks for 8 months. So these are the types of your Kaposi sarcoma. So they differ morphologically. However, your KS Kaposi sarcoma in patients with immunosuppression resembles your classic Kaposi sarcoma. So for Kaposi sarcoma, it's important to note that it's not only associated with the HIV. The common notion is when patients have Kaposi sarcoma, they automatically have HIV. However, there are different types of the Kaposi sarcoma. And these are actually seen in common in patients with Southern and Eastern European origin and those living in tropical Africa. Sorry. Okay. So other types include your atypical vascular lesion and your angiosarcoma. So for your angiosarcoma, uh, this actually occur on the head and neck of elderly people with male-female ratio of 2 is to 1, and it often begins as a poorly defined bluish macule that may be mistaken for a bruise. So distinguishing features are the frequent occurrence of your peripheral erythematous ring, satellite nodules, presence of your intratumoral hemorrhage, and the lesion's tendency to bleed spontaneously or after minimal trauma. So we proceed to your fibrous tumor, as you all know this, the keloid, which um, usually arises as a result of your cut, laceration, or burn, or less often an acne pustule on the chest or the upper back. And you would note that it spreads beyond the limits of the original injury, often sending out claw-like prolongations. So you have to distinguish your keloid from your hypertrophic scars by their claw-like projection, which are absent in your hypertrophic scars. So for your keloid, there are claw-like projections. On histology, you would note a dense and sharply defined nodular growth of the myofibroblast and collagen with a whorl-like arrangement resembling your hypertrophic scar. There is, however, a thick hyalinized bundles of collagen and treatment includes your interlesional triamcinolone suspension for 6 to 8 weeks. You can also give your 5-FU, your methotrexate, your verapamil, your long pulse NDIAD, or your CO2 laser excision. So you can also combine surgical excision with your intralesional steroid or your interferon alpha 2B and your silicone sheeting sheet gel and pressure. So we also have your duodenal contracture and your plantar fibromatosis. So for your duodenal contracture, these are actually fibromatosis of the palmar aponeurosis, while your plantar fibromatosis is a plantar analog of your duodenal contracture. Treatment includes your intralesional triamcinolone or collagenase or your you will perform your percutaneous nodal fasciotomy. And another type of your fibrous tumor is your Peyronie disease, which is uh, a fibrous infiltration of the intercavernous septum of the penis. So the fibrosis results in the formation of nodules or plaques, and as a result of these plaques, a fibrous cortex is produced, and curvature, as seen in the picture, of the penis occurs on erection, sometimes so severe as to make intromission difficult or impossible. So in some patients, the pain may be severe, and your Peyronie disease can also be associated with your Dupuytren contracture. So injection of your interferon alpha 2b verapamil collagenase can be used, as well as your triamcinolone, and oral therapies may include your vitamin E, your para-aminobenzoate, your colchicine, your tamoxifen, and your acetyl carnitine. But data supporting your oral therapy are weak, so your surgical correction, tailored to the degree of your deformity, is often successful, and you can also do your extracorporeal shockwave therapy, which can reduce your penile pain, but however may worsen the curvature. So other types of your fibrous tumors include your lipofibromatosis, which is a rare tumor of infancy, presenting as a poorly demarcated, slow-growing soft tissue mass on an extremity, and this may be associated with your syndactyly, cleft lip and palate, your atrial septal defect. So for your knuckle pads, so as you can note, this these are well-defined, round, plaque-like fibrous thickenings developing on the extensor aspects of your proximal interphalangeal joints of the toes and your fingers. We also have your pachydermadactyly, which are benign fibromatosis of the fingers. Another is your desmoid tumors. They occur as large, deep-seated, well-circumscribed masses arising from your muscular aponeurosis. So this frequently occur on the abdominal wall, especially in women during or soon after pregnancy. So we have five types. We have your abdominal wall, extra-abdominal, intra-abdominal, multiple, and those occurring in patients with Gardner syndrome and or familial adenomatous polyposis. So for desmoid tumor, we can do your wide local excision. However, we can also do your high dose tamoxifen and sulindac, which are also effective. For mesenteric desmoid tumor, we give you anti-angiogenic therapy with chlorimifen and interferon alpha 2b, as well as your imatinib and. So another type is your collagenous fibroma, or known as your desmoplastic fibroblastoma, which are histologically characterized as with hypocellularity and dense bands of hyalinized collagen that may infiltrate into your skeletal muscle. So these are actually slow-growing, deep-set benign fibrous tumors located on your deep subcutis fascia, aponeurosis or skeletal muscle of the extremities, lymph girdles or head and neck regions, including your mucosa. So for your aponeurotic fibroma, this has also been called your juvenile aponeurotic fibroma or your calcifying fibroma. It is a tumor-like proliferation characterized by the appearance of your slow-growing cyst-like masses occurring on the limbs, especially the hands and feet. So an aid to your diagnosis for patients with aponeurotic or fibroma is the presence of your stippled calcification readily seen on radiograph. So treatment of choice for this is surgical excision guided by your MRI. Next is your infantile myofibromatosis, which is the most common fibrous tumor of infancy, and histologically, it presents as fascicles of spindle cells occurring in a whorled pattern. So for your other aggressive infantile fibromatosis, we have your fibrous hamartoma of infancy, which occurs as a single dermal or subcutaneous firm nodule of the upper trunk present at birth or shortly thereafter. So you can see this on your axilla, on your upper arm, on your upper trunk, inguinal region, and external genital area. You also have your tenosynovial giant cell tumor, which is frequently attached to the tendons of the fingers, the hands, and the wrists, and does not spontaneously include. For your immune, so these are known as your dactylisis spontanea or your occurrence. It affects your toes, especially the fifth toe, this one. So as you can notice, there is a linear constriction around the affected digit that ultimately leads to the spontaneous amputation of the distal part. So it may occur unilaterally but may also be bilateral. The cause is also unknown, but the condition may result from chronic trauma and exposure to the elements by walking barefoot in the tropics. Another is your pseudoimmune. So this has been a term used in connection with certain hereditary and non-hereditary diseases in which, as you can notice, there is annular constriction of the digits. So treatment includes your IL injection of your corticosteroids in INFO, and retinoids can also be given. So for other types of your fibrous tumors, this include your connective tissue nevi, also your angiofibroma, which are your skin-colored reddish papules showing fibroplasia and varying degrees of vascular proliferation in the upper dermis. So your angiofibroma may occur as a solitary, non-hereditary form. So this can be seen if it's a solitary, non-hereditary form. This is your fibrous papille of the nose. In those with multiple non-hereditary lesions, they present as your pearly penile papules. And for your multiple hereditary forms, this is associated with your Birt-Hall-Dubé, your tuberous sclerosis, and your MEN1. So as mentioned, your fibrous papille of the nose, these are actually your dome-shaped sessile skin-colored whitish or reddish papules on or near the nose. As for your pearly penile papules, they present as a pearly white dome-shaped angiofibromas occurring circumferentially on the coronal margin and sulcus of the glans penis. So your pearly penile papules are not uncommon. Other types of your fibrous tumors include your cutaneous pseudosarcomatous polyp and umbilical polyp. So these are just benign proliferations with a tag-like configuration, but also dramatic cytologic atypia and pleomorphism. Another is your acrocordon, or also known as your fibroepithelial papilloma, on, or on layman's term is called your skin tag. So these are actually small flesh-colored, dark brown, pinhead-sized and larger sessile and pedunculated papillomas commonly occurring on the neck, often in association with your small seborrheic keratosis. And on histology, you would note that the epidermis is enclosed in a dermal fibrovascular stalk. Treatment includes clipping out at the base with little or no anesthesia, and you can also apply your aluminum chloride for hemostasis. So light electrodesiccation can also be effective. So you would actually note that these lesions increase in number during weight gain or during pregnancy, and this may be associated with your diabetes mellitus and your colonic polyps. So for your dermatofibroma, this is generally a single, round, or ovoid papule or nodule that is reddish brown, sometimes with yellowish hue. It's important to know the dimple sign in dermatofibroma, wherein there is a depression created over a dermatofibroma when it is grasped gently between your thumb and your forefinger. So on immunohistochemical studies, it is positive for your factor 13A, and you would note that there is collagen trapping and basaloid induction in your dermatofibroma. In comparison with your dermatofibrosarcoma protuberans, these are firm, painless lump in the skin that has been slowly increasing in size for several years. So it is positive for your CD34. So again, one difference between the two is your dermatofibroma is positive for your factor 13A, while your DFSP or your dermatofibrosarcoma protuberans is positive for your CD34. So we proceed to your neural tissue tumors. We have your neurofibroma, which is a soft, flaccid, translucent, and pinkish white uh, papule. Frequently, your soft, small tumor can be invaginated as if through a ring in the skin by pressure with the finger, also known as your bottom holding. So infrequently, your large pendulous masses occur in which your numerous tortuous thickened nerves can be felt, and this has been likened to a bag of worms. So when you hear bottom holding and bag of worms, you think of neurofibroma. So if your neurofibroma lesions are less than 2, it's safe to say that there is without internal manifestations. However, if lesions are more than 3, you can consider your neurofibromatosis 1. On histology, you would need a wavy spindle nuclei and fine collagen fibers. And of course, the strum is often mixoid containing many cells. Also, that is positive for your S100. Another type of your neural tissue tumor is your granular cell tumor, which is a firm, painless lump in the skin that ranges from 5 to 30 millimeter with a brownish red or flesh tint depending on nearness to the surface. As for your schwannoma, these are uh, actually elevated dome-shaped nodules, pale brown indurated macules, and multiple papules coalescing into plaques with a predilection for the throat. So in histology, these are well encapsulated with characteristic subscapular edema. So for your schwannoma, it's important to remember your Anthony A and your Anthony A. So for your Anthony A, they are actually palisades of your basophilic Schwann cell nuclei separated by brightly pulsating zones, or what we call your Cherokee bodies, while your antennae are a degenerative change characterized by loose edematous connective tissue and ectatic blood vessels. This tests positive for your EMA, so excision is almost invariably curative except in the malignant variety, for which combined wide resection and radiotherapy is needed. Another type is your infantile neuroblastoma, which is the most common malignant tumor of early childhood. So your cutaneous nodules are most often seen in younger patients, being present in 32% of uh, infants with the disease. So two other findings that may be present in infantile neuroblastoma are your periorbital ecchymosis and your heterochromia on the irises. So these patients have good prognosis for infants with skin involvement. For your nasal glioma, these are rare benign congenital tumors. However, it's important that you distinguish it from your hemangioma and encephalocele if it occurs extranasally. So these are firm, incomprehensible reddish blue to purple lesions. And on histology, you would know presence of your glial giant cells, fibrous tissues, and induced blood vessels. So it is also unencapsulated, and these lesions do not inhibit spontaneously. So other type of your neural tissue tumor is your cutaneous meningioma, which results from the presence of your meningocytes outside the calvary. So they usually come to medical attention in the first year of life. Um, on the scalp, they may present with a dark tuft of hair on an alopecia area surrounded by a dark color of hair, which is also called your hair color sign. So on histology, tumors consist of vascular-like anastomosis spaces with spindle cells forming whorls around collagen bundles, and your laminar calcified amino bodies are often present, however, are not specific. So we can give your international triamcinolone suspension, or 5-FU methotrexate, verapamil, etc. So the primary defects in the neural tube may lead to your encephalocele and your meningocele or meningomyelocele. So your cutaneous manifestations of your spinal dystrophism may include your depressed or polypoid lesions, your dyschromic or hairy lesions, your dermal or subcutaneous lesions of your vascular malformations, or neoplasms of many types. The MRI is the imaging modality of choice, and we proceed to your fat tissue tumor. First is your lipoma. So these are soft, single, multiple, small, or large lobulated compressible growths over which the skin and traction often becomes dimpled, although otherwise unchanged. And on histology, we would note unencapsulated lobulated tumor containing normal fat cells here held together by strands of your connective tissues. So another is your nevus lipomatosis superficialis, which are your soft yellowish papules or cerebriform plaques, usually on the buttocks or thighs, and less often on the ear or scalp with a wrinkled rather than warty appearance. So clinically, diba kamukha niya yung lymphangioma circumscriptum, as discussed a while ago. Other tumors include your folded skin scarring or Michelin-Tire-Baby syndrome. So they resemble a stacked tire. We also have your benign lipoblastoma, which is frequently confused with your liposarcoma. So it actually affects infants and young children exclusively. And we have two forms. We have the circumscribed form. So this is superficially located and clinically comparable to a lipoma, while your diffuse form is more deeply situated and is analogous to your diffuse lipomatosis. As for your liposarcoma, these are the most common soft tissue sarcoma, and they usually arise from your intermuscular fascia and rarely from the subcutaneous fat. So they do not also arise from your pre-existing lipomas, and consider liposarcoma if your tumor is more than 10 centimeters in diameter. Next is your smooth muscle tumor. So this is just an excerpt from your Fitzpatrick book. So this is just a summary of the different smooth muscle tumors. So we have your leiomyoma, your angiomyoma, your genital leiomyoma, and your leiomyosarcoma. So in general, your cutaneous leiomyomas are smooth muscle tumors characterized by painful nodules that occur singly or multiply. So they can be separated conveniently into solitary and multiple cutaneous leiomyomas arising from your erector pylorus muscles, in leiomyoma, or your solitary genital leiomyomas arising from your deltoic, bulbar, or mammillary muscle. So as you can note, what's common is that leiomyomas are actually tender, except for your genital myoma, which is usually painless. So other miscellaneous tumors and tumor-associated conditions include your cutaneous endometriosis, which are characterized by the appearance of brownish papules at the umbilicus or in lower abdominal scars after gynecologic surgery in middle-aged women. We also have your teratoma and your metastatic or malignant tumors, carcinoma. So your malignant tumors are able to grow at sites distant from the primary site of origin, and dissemination to the skin may occur with any malignant neoplasm. So for example, we have your carcinoma erysipelatioides, which is characterized by your erythema, edema, warmth, and well-defined leading edge, similar to your erysipelas in appearance, well-defined. So this is usually caused by your breast carcinoma, but has been reported with many other primary tumors. So conditions that are also related to your breast carcinoma include your carcinoma enchyvase, which is uh, characterized by an indurated and hidebound leathery quality of sclerodermoid change in the skin. We also have your carcinoma telangiectaticum. Another is your alopecia neoplastica, which may present as a cicatricial localized area of hair loss. So it is actually also seen secondary to your metastatic breast cancer. Another is the so-called Sister Mary Joseph nodule. So this is formed by localization of your metastatic tumors to the umbilicus. So the most common primary sites are your stomach, your large bowel, the ovary, and your pancreas. And you also have your lymphangiosarcoma, which develops in the site of chronic lymphedema, such as in breast cancer patients who have had lymph node resection. So you also have your paraneoplastic syndromes. First is your Bazek syndrome or your acrokeratosis paraneoplastica. This is characterized by violaceous erythema and scaling of the fingers, the toes, the nose, and oral varices. These are actually secondary to primary malignant neoplasms of the upper ear digestive tract or metastatic cancer to lymph nodes, often in the cervical region. So another is your glucagonoma syndrome. So it is characterized by weight loss, glucose intolerance, anemia, ascites, and your migratory erythema. So erythematous patches with bullae and light brown papules with scales involves the face, the groin, and the abdomen, characterized as skin eruption. So these are seen in your glucagon secreting tumors of the pancreas. Another is your erythema gyratometens. So in the picture, you would note a gyrate, serpiginous erythema with characteristic wood grain appearance or wood grain pattern scales, and it is almost always associated with your underlying malignancy. Another is your prosusine or your migratory thrombophlebitis, usually seen in pancreatic cancers or pancreatic carcinomas. And we also have your hypertrichosis lanuginosa in acquisita or your malignant down, in which there is a sudden growth of your profuse, soft, non-methylated, non-pigmented downy hair in an adult. And these are commonly reported in patients with lung and colon cancer. Another is your sign of lesser chelasine. There is a sudden appearance of your multiple pruritic seborrheic keratosis associated with your internal malignancy. So other paraneoplastic syndrome cutaneous findings include your acquired ichthyosis, your pityriasis rotunda, also your trichomes seen in patients with uh, carcinomas, GI carcinomas. So we proceed to your epidermal nevi, neoplasms, and cysts. So for your benign epithelial tumors, so epidermal nevi are actually hamartomatous growth of the epidermis that are present at birth, and about half of patients are developed early in childhood. So types of your epidermal nevi include your keratinocytic epidermal nevi, your nevus sebaceous, and your nevus comedonicus. So this suggests that your epidermal nevi should be classified according to their histologic phenotype. And among this, your keratinocytic epidermal nevi is the most common type of your epidermal nevus, and uh, your epidermal nevus syndrome may be associated with your internal manifestations, including your primary skeletal abnormalities and less often your central nervous system manifestations. Treatment includes your 5-FU with retinoid, cryotherapy, topical corticosteroid, and calcipotriene, laser surgery, and excision. So for your nevus comedonicus, it is characterized with closely arranged loop, often linear papules that have at their center dilated follicular openings with keratinous plugs resembling your comedones. So they are most frequently lateral, although bilateral cases are also seen and they occur mostly on the trunk and follow the lines of your Blaschko. Treatment includes your topical tretinoin, your ERIAG or the CO2 laser, and surgical excision. However, patients with your inflammatory lesions are much more difficult to manage. So we can also give your oral isotretinoin at 0.5 milligram per kilogram per day. However, many cases fail to respond. Another is your seborrheic keratosis. So this presents as oval, slightly raised tan or light brown to black, sharply demarcated papules or plaques are rarely more than 3 centimeters in diameter. So as you can see, they appear stuck on the skin as they could be removed with the flick of a fingernail. The surface of the warty lesions often becomes crumbly, resembling a loosely attached crust, and when this is removed, a raw moist base is revealed. So as mentioned a while ago, diba, your lesser threat sign is the sudden appearance of your numerous seborrheic keratosis, commonly seen in GI adenocarcinoma. And treatment includes your liquid nitrogen, your curettage, your fulguration, and you can also do your shave excision or your shave removal. So another is your dermatosis, papillosa nigra. So this appears as minute, round, skin-colored hyperpigmented macules or papules that develop singly or in sparse numbers on the malar regions or on the cheeks below the eyes. So the lesions increase in number and size over time, and these lesions do not spontaneously resolve. Hence, we can do your liquid nitrogen, your curettage, your fulguration, and your shave removal. So same with your seborrheic keratosis. So before proceeding to our epithelial precancerous lesions, can we have a 5-minute break?
Yes po, Doctor.
Thank you. Hello. Good morning. Okay, let's start again. So for your epithelial precancerous lesions, we have your actinic keratosis. So they represent in cytodysplasias resulting from your sun exposure. So your AK are the most common epithelial precancerous lesions, and although lesions typically appear in persons over age 50, actinic keratosis may occur in the 20s or 30s in patients who live in areas of high solar irradiation and have fair skin. Patients with actinic keratosis have a propensity for the development of non-melanoma cutaneous malignancies, and this can be prevented by the regular application of your sunscreen and low-fat diet. So they present as multiple discrete, flat, or elevated verrucous, or keratotic red, pigmented, or skin-colored lesions. Usually, the surface is covered by an adherent scale, and sometimes it is smooth and shiny. So, on palpation, the surface is rough like sandpaper, and at times lesions are more easily felt than seen. So they are found chiefly on the chronically sun-exposed surfaces of the face, ears, balding scalp, dorsal hands, and forearms. Treatment includes your cryotherapy with liquid nitrogen, which is most effective and practical. So we can also give your topical chemotherapy, extensive broad numerous 5-FU immediate cream, and diclofenac gel. For surgical removal, we can do your chemical peeling, your laser resurfacing, and your photodynamic therapy. Another is your keratoacanthoma. These are actually solitary, multiple eruptive kerato. So these are actually the four types of your keratoacanthoma: your solitary, your multiple, your eruptive, and your keratoacanthoma centrifugal marginatum. So this rapidly growing papule enlarges from a 1 millimeter macule or papule to as large as 25 millimeters in 3 to 8 weeks. So one uh, characteristic of keratoconoma is its rapid growth followed by a stationary period and spontaneous involution. Common sites include your sun-exposed skin of the face, dorsum of the hands and the arms, and you can do your excisional biopsy or your intralesional injections of your 5-FU, bleomycin, or methotrexate patients with KA. You can also give your low-dose systemic methotrexate and your radiation therapy. So we proceed to your non-melanoma skin cancers. Melanoma skin cancer. So it appears that your BCC arises from your premature pluripotential cells associated with hair follicles, and there is mutations that activate the hedgehog signaling pathway, controlling your cell growth, found in most of your disease. So intermittent intense sun exposure as identified by your prior sunburns, positive family history of BCC, immunosuppression, a fair complexion, especially your red hair, easy sunburning, with those with skin types 1 or 2, Fitzpatrick skin type 1 or 2, or your blistering sunburns in childhood are risk factors for the development of your BCC. Your indoor tanning is also a strong risk factor for your early onset BCC, particularly among women. Although in the Philippines, of course, hindi naman uso yung intertandem. So there are different BCC morphologies. We have your nodular, your cystic, sorry ha, maingay ha. Your morpheiform, infiltrative, micronodular, superficial, pigmented, rodent ulcer, fibroepithelial actintus, polypoid BCC, core-like BCC, aberrant BCC, and BCC in young person. Sites include your face, so especially on the head and neck, on the nose, forehead, ears, periocular areas, and the cheeks. So, as you can notice in the lesion, so for your classic or nodular BCC, they are actually composed of a few small, waxy, semi-translucent nodules forming around a central depression that may or may not be ulcerated, crusted, or is bleeding. So the edge of the larger lesions has a characteristic road border. So here, and telangiectasias course through the lesion. Your bleeding on slight injury is a common sign, and as growth progresses, your crusting appears over a central erosion or ulcer. And when the crust is knocked or kicked off, your bleeding occurs and the ulcer becomes apparent. So this ulcer is characterized by your chronicity and gradual enlargement over time. Your BCCs runs a chronic course as the lesion slowly enlarges and tends to become more ulcerative, and as a rule, the lesions tend to bleed without pain or other symptoms. Peripheral spreading may produce your configurate somewhat serpiginous patches, and ulceration may burrow deep into the subcutaneous tissues or even into the cartilage and the bones, which may cause extensive destruction and mutilation. So, as for your metastases, it is extremely rare, and this low rate is believed to occur because the tumor cells require supporting stroma to survive. So, in comparison with your SCC, your immunosuppression does not appear to increase the risk of your metastasis or your BCC. So, for the treatment, so it is important that we thoroughly evaluate individual lesions for your BCC, and we should take in account the age, the gender of the patient, as well as the size, site, and the type of lesion when choosing the proper method of treatment for patients with BCC. So the choice of treatment should be influenced by the experience and ability of the treating physician, and a biopsy should be performed in all patients with suspected BCCs in order to determine the histologic subtype and confirm the diagnosis. So your aim for the treatment of your BCC is permanent cure with the best cosmetic results. Hence, your surgical intervention is the treatment of choice for BCC. However, topical therapy may include your superficial BCC, your 5FU, uh, and your imiquimod. Also, your photodynamic therapy and your PDT can also be given. As for your squamous carcinoma, it is the second most common form of your skin cancer. So most cases of your SCC are induced by your UV radiation, and chronic long-term sun exposure is the major risk factor. And areas that have had such exposure are favored locations. So common sites include your face and hands. So early lesions are noted to have superficial, discrete, and hard arising from unindurated, rounded, elevated base with dull red uh, color and telangiectasia and is localized and freely mobile. And advanced lesions are characterized by your cauliflower-like lesions composed of densely packed filamentous projections between which are clefts filled with a viscous, purulent, malodorous exudates. So associated conditions include your carcinoma of the respiratory organs, your buccal cavity pharynx, your small intestine, your non-Hodgkin lymphoma, and leukemia. And as for the metastatic rate, it is also low, zero point 0.5 to 5.2%, but higher in BCC. So risk factors for your metastasis include your lips, ear, and anogenital involvement, your chronic scarring, your irradiation, lesions more than 2 centimeter in diameter and more than 4 millimeters thickness, recurrent, poor histologic differentiation and perineural invasion, and organ transplantation or hematologic malignancies. Treatment includes your surgery, which is your primary mode of treatment. We can also give you oral retinoids, your photodynamic therapy, and advise sun protection. So next is the Bowen's disease, which is an intraepidermal skin cell carcinoma. So multiple possible agents can induce your Bowen's disease, including your HPV of certain types, your arsenic exposure, and your sun exposure and UV radiation exposure. So the origin of the cells developing into BD is unknown, but might be a pluripotential epidermal cell. So your Bowen's disease may be found on any part of the body as an erythematous, well-defined, slightly scaly, encrusted, non-infiltrated patch from a few millimeters to many centimeters in diameter, and the lesion is sharply defined. So treatment includes your imiquimod 5% cream, 5-FU, and tazarotene, and your simple excision of small lesions is a reasonable treatment option. We can also do your Mohs microsurgery and your curettage and desiccation. Next is your erythroplasia of Kerat in SCC in situ of the glans penis or prepuce. So SCC in situ on the penile shaft can be caused by your high-risk HPV types, including your HPV type 16, 18, 31, and 35. And clinically, your erythroplasia of Kirat is characterized by your single or multiple fixed, well-circumscribed erythematous moist, velvety, or smooth red surface plaques on the glans penis. So, as for your treatment, your topical therapy can be effective, such as your topical 5-FU, your imiquimod 5% cream. However, we can also do your excision, your laser, your PDT, and your radiation therapy. Next is your Paget's disease. So we have your Paget's disease of the nipple affecting women primarily, and it is characterized by a unilateral, sharply marginated erythematous and at times crusted patch or plaque affecting the nipple and occasionally the areola. So at times, it may be hyperpigmented and can also mimic your melanoma. The presence of your unilateral eczema of the nipple recalcitrant. Simple treatment should lead to the suspicion of your Paget's disease. So, uh, sorry, medyo maingay. Anyway, medyo malapit na tayo matapos. So, next is your tumors of your sebaceous glands. We have your nevosebaceous. These are actually seen at birth or childhood with somatic mutation in your HRAS or KRAS gene. So it is also associated with your Schimmelpenning syndrome, ophthalmologic ophthalmologic CNS, urologic, and CV abnormalities in combination with your nevosebaceous. So that is your Schimmelpenning syndrome. These are actually characterized by your sharply circumscribed yellow-orange hamartoma, slightly papillated or velvety in child, elevated and cerebriform in adult, and uh, this is actually solitary, congenital, or linear in configuration. So the most common location is the scalp, and uh, treatment includes your excision. So sebaceous hyperplasia is also a type of sebaceous tumors, and it occurs in 15% of patients taking cyclosporine and may involve ectopic sites such as your oral mucosa. It often appears many years after the cyclosporine is begun. So histologically, sebaceous hyperplasia demonstrate a hyperplasia of one sebaceous glands with normal sized surrounding glands. And treatment includes your electrosurgery, laser therapy, PDT, and shallow shave biopsy. Sweat gland tumors include your syringoma, which are the common neoplasm with a sweat duct differentiation. This appears as multiple yellow, brown, or pink small papules, 1 to 3 millimeters in diameter, and they develop slowly and persist indefinitely without symptoms. So these are commonly seen on your eyelids and upper cheeks, and treatment is difficult and may respond to very light electrodesiccation or cautery or your shave removal, also your CO2 laser and your surgical removal. So last part is second to the last are your epithelial cysts. So your epidermal cysts, they frequently result from the plugging of your follicular orifice, often in association with your acne vulgaris. So these are also called your epidermal inclusion cysts or your epidermoid cysts, which are the most common benign skin tumors. It is rare before puberty, and uh, you would actually note macerated keratin and cheesy pasty consistency and pungent odor content of your epidermal cyst. Common location include your face, your neck, and trunk, and treatment includes your surgical excision. For ruptured cyst, we do your IND. So to note, if any fragment of the cyst wall is left behind, your cyst may recur. So it's important that you also remove the cyst wall. So alternatively, what you can do is uh, you eradicate the cyst lining of the cyst by cauterizing it with your 20% trichloroacetic acid. Another type of your epithelial cyst is your pilar cyst, also known as your tricholemmal cyst. It is also known and similarly clinical. It is actually clinically similar to your uh, epidermoid cyst. However, 90% of your pilar cysts occur on the scalp, and women over age 60 are predominantly affected. The cyst may be found rarely on the face, trunk, and extremities, and an overlying punctum is not present, and lesions tend to be more mobile and firmer than your epidermal cyst. So when you compare, there is a central punctum in your epidermal cyst in comparison with your pilar cyst. Next is your dermoid cyst, as discussed a while ago, di ba? We already mentioned this one. So these are also called your congenital inclusion dermoid cysts, which can be commonly seen on the face, including your lateral eyebrow, your nasal root along the midline of the forehead over the mastoid process, on the floor of the mouth, and anywhere along the midline of the scalp from the frontal to the occipital region. So treatment for children with dermoid cyst includes ruling out first your intraspinal or intracranial communication. So your CT or MRI is required before your surgical intervention. Next is your milia, which are your keratinous cysts, 1 to 4 millimeters in diameter. They are white and easily seen as cystic through the overlying attenuated skin, and it is common, and there are multiple clinical patterns of milia that have been described. So they are usually not managed by dermatologists, but by surgeons. Sorry, nakamute pala. Anyway, lastly, we have your cutaneous columnar cyst. So there are different types of your cutaneous columnar cyst, including brachial cleft cyst and your thyroglossal duct cyst, which is the most common cause of your congenital neck anomalies in the childhood. For your thyroglossal duct cyst, clinically, uh, these are usually not managed by dermatologists but by surgeons. We also have your median rhapsodies of the penis. So these are developmental defects lying in the ventral midline of the perineum here from the anus to the urethra, most often on the distal shaft near the glans. So they most frequently present as your dermal lesions of less than 1 centimeter in young men, and they may appear suddenly after your sexual intercourse associated trauma. So another type of your cutaneous columnar cyst is your congenital preauricular fistula, which occurs as a pit in your preauricular region, often in several members and generations of a family. So on each side, just anterior to the external ear, and there is a small dimple here for our fistulous opening that may extend as far as the middle ear, and most congenital Pre-auricular fistulas are benign and they do not require surgery. So complications of your surgery are common, and complete excision of both the pit and the sinus tract should be the goal of if surgery is attempted. So that is the first part of our discussion on neoplasia. So chapter 30 will be discussed next meeting together with the disorders of your skin appendages. Okay, so let's meet next meeting for our second lecture. Okay. So thank you. If you have any, do you have any questions before we end this meeting? So if there are no questions, or you can actually save it for our next meeting. See you next Monday. Okay. So thank you.